Dr. Beth LaBardi is a geriatric psychiatrist in Seattle with clinical roles at the VA Puget Sound Healthcare System and academic appointment as a clinical assistant professor at UW Medical Center. She received her medical degree from Georgetown University School of Medicine, completed psychiatry residency at the University of Illinois in Chicago, and a geriatric psychiatry fellowship at Northwestern University. She is the geriatric mental health coordinator for VA Puget Sound, working in the outpatient mental health setting as well as in long-term care and the dementia specialized care unit at the VA. She's also the geriatric psychiatry education coordinator for UW's psychiatry residency program. She's lectured on a wide range of topics within geriatric mental health care and has published on the topics of psychiatric management of medically complex geriatric patients and on neurodegenerative disorders. So she's a tremendous expert to speak to us today about psychosis in late life. And welcome, Dr. LaBardi.
Thank you so much, Barb. And thank you to everyone who is attending on this lovely Valentine's Day evening. I'm eager to talk to you about a really complicated and interesting topic, but acknowledge that it is neither romantic nor gives me the opportunity to shower anyone with chocolate. So thanks for spending your time here. I have no financial disclosures at all. I wish I did. I will discuss some off-label use of antipsychotics for dementia-related psychosis, given the sparsity of FDA-approved medication for this indication. I will present evidence as available as I'm talking through that, though. This is such a big topic. I'm hoping that we can come away with a few primary objectives for the talk. One is be able to appreciate how heterogeneous the causes of psychosis in later life are. List the important steps in the diagnostic evaluation of late life psychosis, and then be able to appreciate the role as well as the limitations and risks of antipsychotic medications in our older patients. So psychosis, what is it? Well, it's not specifically defined in the DSM or ICD classification systems. What we mean by psychosis is really psychotic features that are thought to generally include delusions, hallucinations, disorganized thinking, disorganized motor behavior, or negative symptoms. And by negative symptoms, we mean 5 things that comprise those: a blunted affect, alogia or decreased verbal output, avolition or decrease in motivation or initiation, asociality, so social withdrawal, and anhedonia, lack of pleasure, enjoyment. Now, we think of psychosis often as being psychotic disorders that cluster in the DSM under this group called schizophrenia spectrum or other psychotic disorders, because these are disorders that have these symptoms as really hallmarks of the diagnosis. Psychosis in late life is much broader than just psychotic disorders, though. It's, first of all, really not uncommon, surprisingly not uncommon in the geriatric population. In a Swedish investigation of 85-year-old individuals in Sweden, the prevalence of psychotic symptoms was actually about 10%, 10.1%, so surprisingly not uncommon. The etiologies are really varied in late life, so we're going to focus a lot on that today. And not only are the etiologies varied, but psychosis seems to develop due to really complex interactions of etiologies. Various biological, psychological, social, and environmental factors can contribute to the onset of psychosis. Like with many mental health conditions in late life, there's a greater prevalence of psychotic symptoms than actual psychotic disorders in a geriatric population. The clinical presentations can be variable, which we'll also talk about. And psychosis in late life is associated with elevated morbidity and mortality, really regardless of the etiology. So it is important to know about it, to know how to identify it and properly address it. So because the etiologies are so varied, we're going to break it down into 2 main groups here: primary psychosis and secondary. Primary psychotic disorders are what I have listed here, these conditions where psychotic symptoms are really part of the core symptoms of the disorder. It's necessary for the diagnosis. Schizophrenia is the one we may think of the most, but under these schizophrenia and psychotic spectrum disorders also includes schizoaffective disorder, schizophreniform disorder, brief psychotic disorder, and delusional disorder. If you're not familiar with some of those later listed ones, I will briefly mention them later in the talk so you're familiar. Now, not primary psychotic disorders, but primary psychiatric conditions I'm also going to mention because they're really pertinent in a geriatric population, are affective disorders and personality disorders, in which some of them actually can have psychotic symptoms associated with those conditions. So I'll cluster that under the primary cause since it's a primary psychiatric condition. Secondary causes are really notable because the etiology of psychosis in late life is really different than younger individuals, and secondary causes are much more common and so wide-ranging. Secondary psychosis really is psychosis that is a symptom of another disorder. So neurocognitive disorders, delirium, substance use or medications, and a number of other medical or neurological disorders, Parkinson's disease being just one example. Now, secondary causes of psychosis comprise about 60% of the cases of psychosis in late life. So since the etiology is so varied, and secondary psychosis is actually more common, when an older adult presents with new onset psychotic symptoms, or psychotic symptoms that are very different from their baseline or that they've experienced in the past, we are going to entertain a broad differential. It is important that we do this so that we can identify the cause and address it, again, because psychosis in older adults is so associated with elevated morbidity and mortality. Until proven otherwise, assume that new psychotic symptoms in an older adult are secondary, so that the initial workup really should focus on these potential causes. Individuals with secondary psychosis, compared to those with a primary psychotic disorder, are more likely to have an atypical age of onset, i.e. older. They are more likely to have visual hallucinations independent of auditory hallucinations, which is different than schizophrenia, where auditory hallucinations are actually more common. They are less likely to have previous psychiatric history or family psychiatric history as well. So what are the steps we need to take as we go through a differential diagnosis and workup? Given that secondary causes are what we are wanting to rule out above all else, we want to start with a good medical and neurological workup. So this includes, of course, a history, not just from the patient, but from collateral sources as well. With psychosis, we kind of want to address this like we would a dementia evaluation, where history from a collateral source is just as important. Then we want to get a physical and neurological exam, of course, some basic labs, and you'll see these really are similar to what we would do if we were doing a dementia evaluation and an evaluation for potential causes of delirium. Those both being potential causes of psychosis. That's kind of what this part of the workup will look like. May want to consider neuroimaging, particularly if there are focal neurological symptoms or if there's a recent history of cognitive decline. Now, this workup could reveal a number of potential causes of psychosis, including infection, endocrine abnormalities. I'm going to talk through just a couple common etiologies here that could be identified at this stage in your workup. Psychosis and delirium is a really important one that could be identified at this point. Of course, delirium is particularly common in older patients because they are more at risk. How do we identify that psychosis is due to delirium outside of a potential medical cause of delirium? Well, the psychosis is going to be acute in onset. It's going to have a fluctuating course, just like we expect with the level of consciousness in delirium. Psychotic symptoms will also fluctuate. Delusions that may present tend to be unsystematized and fragmented, unlike a primary psychotic disorder where they may be very involved, specific, and focused. They may fluctuate with time and be rather disorganized. With the identification of delirium, you want to look for new cognitive deficits along with the psychotic symptoms, inattention specifically, because that is the cognitive hallmark of delirium. The prevalence of psychotic symptoms in delirium is 42.7%, so it is rather a common cause. Visual hallucinations are the most common type of hallucination in delirium, followed by auditory and tactile hallucinations. Delusions are prevalent at about 25.6%. Another source of psychosis that could be identified at this stage doing your medical and neurological workup is psychosis related to Parkinson's disease. So in the setting of Parkinson's disease, hallucinations, particularly visual hallucinations, are going to be more common than delusions. And these symptoms are common. Somewhere between 10 and 40% of patients with Parkinson's disease will have psychotic symptoms at some point in their illness. Some risk factors for psychotic symptoms are, you'll see some of these kind of go together. Higher dopaminergic medication load, since we know excess dopamine can further drive psychotic symptoms. Disease severity, which of course, as the disease becomes more progressed, someone may receive more anti-Parkinsonian medication. Cognitive impairment, which again also goes with disease progression. Poor visual acuity increases the risk of psychosis, particularly visual hallucinations. And then comorbid depression also seems to increase the risk of experiencing psychosis in Parkinson's. Psychosis is a poor prognostic indicator in this population. It is actually more disabling than the motor symptoms of Parkinson's disease. It causes more caregiver distress and threatens the ability of a patient to remain at home. So whatever cause may have been identified at that point, if that workup is positive, that medical and neurological workup is positive for some underlying condition that could cause psychosis, we're going to, of course, focus on treating that underlying organic cause as our next step in treatment. If that workup was unrevealing, the next step we're going to move to in our differential diagnosis and workup is taking a real thorough look at medications and substance use. So this will include a thorough record of prescribed medications and over-the-counter agents. Plenty of people like taking those. Good substance use history and a urine toxicology. So it's important to note that any medication can cause late life psychosis. Older adults are more vulnerable to adverse effects of medications across the board. The most commonly offending agents that can cause psychosis, though, are break down into these few different groups. So anti-Parkinsonian or dopaminergic medications, as we just discussed with the Parkinson's disease patients, the higher the load of these medications, the greater the risk of psychosis. Anticholinergic agents, sedative hypnotics, which can also cause psychosis in the setting of withdrawal, and then stimulants. With over-the-counter agents, antihistamines and sleep aids particularly can be problematic, so make sure you're asking about those PM formulations that people with difficulty sleeping might like to select. Regarding substance use, the really important thing is just to ask. It's important to remember that people do continue to use substances late in life. That's what we've learned about substance use disorders in a geriatric population. They do not go away. They continue. Cocaine, methamphetamines, obviously psychedelic agents can cause psychosis, and other substances like alcohol, sedative hypnotics tend to cause psychosis in the withdrawal state. So if this part of the workup is revealing for agents that could be potentially offending, of course, we want to stop those as our next step. And then treat the withdrawal, of course, knowing that with some agents, that's going to be the point that causes psychosis and could be potentially harmful. And of course, if someone appears to have a substance use disorder, we want to get them in treatment for that. If this part of the workup is not revealing, we're going to move on to a cognitive evaluation as our next step. So this is really where we dive into a dementia evaluation. Get a cognitive history. If neuroimaging wasn't done previously, now would be a good place to entertain that, particularly to rule out secondary causes like NPH, a new stroke, tumor, could also be helpful in the diagnosis and phenotype of a dementia. And then do some type of cognitive testing, consider referring for neuropsychological testing. Some of these patients presenting with late life psychosis can be really complicated, and it can be really difficult to piece out the role of a potential neurocognitive disorder in causing some of those symptoms. Neuropsychological testing, of course, can be helpful in phenotyping a dementia if that appears to be present. So dementia-related psychosis is the most common reason for psychosis in late life, period. The overall pooled prevalence of psychosis in dementia's cross-phenotype is about 40%, so very common. Psychotic symptoms can convey greater cognitive and functional deficits on the person with dementia than those who do not experience psychotic symptoms. The risk of mortality is higher in those with psychosis. It's not entirely clear why. We do know that folks with psychotic symptoms are more likely to receive antipsychotics, which increase the risk of mortality. They're also more likely to be hospitalized, to be put in restraints, and to fall. So a number of things that could increase morbidity and mortality. Now, compared to schizophrenia, psychosis in the setting of dementia is more common in women. It's less likely to have complex or bizarre delusions. Delusions, when they occur, are commonly persecutory or paranoid. A common example might be the belief that someone is stealing from them. A little separate from delusions is this idea of misidentification, which is also more common in the setting of dementia-related psychosis. This is like misidentifying caregivers or other individuals, feeling that their house is not their home. Visual hallucinations are more common than auditory hallucinations. And dementia-related psychosis is unlikely to be associated with thought broadcasting or control of thought. These are what we call Schneiderian first-rank psychotic symptoms that are present most typically in schizophrenia. We don't tend to see them in dementia hardly ever. And unlike schizophrenia, those with dementia-related psychosis are likely to have that psychosis eventually remit, very likely, in fact. So the treatment and management is different. So looking across dementia phenotypes here, Alzheimer's disease is, of course, the most common type of dementia. The prevalence of psychosis in Alzheimer's disease is estimated at 41.1%. Delusions are more common than hallucinations in Alzheimer's disease. In vascular dementia, the prevalence is estimated at about 15%. Again, delusions being more common than hallucinations. Dementia with Lewy bodies is a little different because this is a condition, this is a dementia where psychotic symptoms are actually a hallmark of the disease. Particularly visual hallucinations, and psychosis is much more common. 78% of those with dementia with Lewy bodies have hallucinations, and 25% have delusions. The visual hallucinations are again more common than auditory, and the visual hallucinations tend to be well-formed and detailed. In a classic sense, dementia with Lewy bodies is associated with what we call Lilliputian hallucinations, which are well-formed, vivid, very realistic hallucinations of small people or animals. That's very classic, though again, visual hallucinations in any form can be associated. Now, regarding Parkinson's disease dementia, that I did not include, given that we spoke about Parkinson's disease in the medical and neurological workup component. But again, keep in mind, Parkinson's disease dementia is going to convey an even higher risk of psychosis because cognitive impairment in Parkinson's disease and advanced Parkinson's disease is a greater risk for experiencing psychotic symptoms. FTD, I did not include. There's actually a real scarcity of available information and publication on psychotic symptoms in the setting of frontotemporal dementia, though it's thought it may be as common as Alzheimer's disease. So if our cognitive evaluation is revealing for a likely dementia, we're going to start addressing those psychotic symptoms in the setting of how we would address behavioral and psychological symptoms of dementia. And I'll talk a little bit about that later, how we might initiate addressing those symptoms in the setting of a dementia. Now, if this workup is not revealing for any type of cognitive impairment, we're going to move on and assess for primary psychotic symptoms. If this patient with new onset psychosis may in fact have a primary psychotic disorder. So as part of this, we're going to dig deeper into history of previous psychiatric illness, the family psychiatric history, and make sure we have a psychosocial assessment. Primary psychotic disorders, again, these are the ones we're talking about. Schizophrenia has a prevalence of 0.1 to 0.5% in older adults, noting that the lifetime prevalence of schizophrenia in the general population is actually 1%. The lower prevalence in older adults is primarily accounted for by a shorter life expectancy in this population, up to 20 years less than the general population. It is notable that patients have been living longer. Patients with schizophrenia have been living longer in recent decades, though. The increased risk of mortality is certainly due, at least in part, to higher rates of metabolic syndrome, cardiovascular disease, and suicide. Some of these conditions are at least partly related to common lifestyle choices in the setting of schizophrenia and antipsychotic exposure. Other primary psychotic disorders we'll talk about are schizoaffective disorder, which I'll define in a bit. And then worth noting, schizophreniform disorder and brief psychotic disorder are really just disorders that are time limited. They are primary psychotic disorders that look a lot like schizophrenia, but have a shorter duration as listed there. And then I will talk about delusional disorder because it's relevant in the geriatric population as well. So late life schizophrenia. Now, we break it down into these different times of onset because it's really a heterogeneous group here. Early onset schizophrenia, we're talking about onset before 40 years of age. And schizophrenia typically most commonly starts in one's teens or 20s. This is 75 to 80% of cases of schizophrenia. It's worth noting that this group of patients has predominant negative symptoms. So again, that alogia, avolition, blunted affect, anhedonia. They have prominent negative symptoms in addition to the quote unquote positive symptoms of delusions, hallucinations, and disorganization. They're also likely to have a family history of psychotic disorders. Now, as we think of sort of a geriatric population with early onset schizophrenia, so those who have aged into later life with this condition, I really want to emphasize that I think it's a common belief that those with schizophrenia diagnosed in early life have this as a chronic, refractory, and disease that really just worsens with time and leads to a decline in function, etc. That's really not the case. Thanks to a couple of researchers who have followed individuals with schizophrenia over decades, we now know that the course is quite heterogeneous over the long term. Some people actually refer to early onset schizophrenia over the lifespan as the disease of thirds. About a third of people do have that chronic refractory course with significant psychotic symptoms and decline in function into late life. But about a third do remain symptomatic, but actually have relatively stable functioning and may even have some improvement in functioning in their later years. And then there is a third that actually have improvement or potentially remission of symptoms as they age with the disease, potentially full remission of psychotic symptoms. So that does happen, and it's not a negligible portion of individuals. Late onset schizophrenia, we refer to as those diagnosed between ages 40 and 60. This is 20 to 25% of cases. This is more common in women than men, unlike early onset schizophrenia, where the gender difference does not exist. It's about equivalent between males and females. There are less negative symptoms with this later onset schizophrenia, but otherwise, these patients tend to look a lot like early onset schizophrenia patients, just with a later onset. They tend to have family history of psychotic disorders. The trajectory can be similar once diagnosed. And it does seem like something sort of kicks it off. There's changes in sensory deficits, social isolation, can seem to worsen what may have been premorbid paranoid or schizoid personality disorders, and frank psychotic symptoms emerge. Then very late onset schizophrenia, like psychosis, is kind of a unique and perhaps confusing entity to many, including those who research it. It seems those are individuals who are diagnosed after age 60. This is much more likely to be women than men. Negative symptoms are very rare. So those positive symptoms of hallucinations, delusions, or disorganization are what we tend to see. There's less likely to be family history. And then, unlike the two earlier groups that we really think of as a neurodevelopmental disorder, schizophrenia, that's how the disease emerges and then persists in some form throughout much of life. These patients look more like those with a neurodegenerative disorder, though they do seem to be a unique group from those with dementia. These folks are not diagnosed with dementia and do not have a trajectory akin to that. They are more likely to have some more difficulties on neuropsychological testing. They're more likely to have some brain structure abnormalities on imaging, like large ventricles. It is worth noting that all of these groups, though, early onset, late onset, and very late onset schizophrenia, like psychosis, are all associated with a higher risk of developing dementia. So a couple other primary psychotic disorders worth mentioning. So schizoaffective disorder is basically when one meets criteria for schizophrenia, as well as an affective or mood disorder like depression or bipolar disorder at the same time. And the psychotic symptoms occur even in the absence of mood symptoms. You can see the prevalence for older adults. Depressive type is more common than the bipolar type. It's more common in women than men, especially when there is later onset. Compared to those with schizophrenia, those with schizoaffective disorder tend to have better community functioning, but also a poorer subjective sense of their physical and mental health. And compared to younger adults with schizoaffective disorder, those that are older adults with the condition tend to have greater severity of their illness and worse outcomes. unfortunately including greater treatment resistance and risk of suicide. Delusional disorders are notable for a geriatric population. They're basically involve some sort of entrenched delusional system with minimal hallucinations, and the hallucinations really only pertaining to that specific delusion. It has to last more than a month. And outside of the delusion, these individuals tend to really retain their social and occupational functioning. You can see the estimated prevalence among older adults is not very common. However, it is more common in older adults. This is a condition that tends to occur in midlife. That's the average age of onset is 49 years old. It's also more common in women than men. And we really have, because of the fact that people don't tend to seek help for delusional disorders, we really have limited knowledge about this disorder in older people. Now, again, these are not primary psychotic disorders, but I think they're really relevant to mention because of how heterogeneous psychosis can be in later life. Affective and personality disorders. So major depressive disorder is notable for psychosis in late life because it is more commonly associated with psychotic symptoms in older adults. It's actually present in about 45% of older patients hospitalized for reasons related to depression. Psychotic depression is also more common in those who are single, widowed, or living alone, sparking the idea that maybe sensory or social deprivation can increase the risk. In psychotic depression in older adults, it's also worth noting that delusions are more common than hallucinations, which is a little different than younger adults with psychotic depression who more commonly have negative auditory hallucinations. In older adults, some of the common themes of delusions in psychotic depression are delusions of guilt. For example, some relatively trivial episode from long ago is currently viewed as a major problem and they need to be punished for it. Somatic delusions, fear of an ongoing disease, often with associated somatic symptoms. And then nihilistic delusions and persecutory delusions are also common. Bipolar disorder rarely has onset in late life, though it can in unusual circumstances. Psychotic symptoms are common in both affective phases, so both depression and mania. The frequency of psychotic symptoms in bipolar disorder in older adults in one study that, a review that pooled 5 studies was 64%, so quite common in the disorder. And psychotic features are actually more common with later onset bipolar disorder. I'm just going to mention this one personality disorder because it can look a lot like psychosis. Paranoid personality disorder is a personality disorder that is rife with symptoms that we sometimes refer to as soft psychotic symptoms that are, of course, associated with sort of paranoid ideas. This is more common in men than women. The prevalence actually increases with age and medical comorbidities, perhaps because people may have more cognitive impairment or confusion, and they may be more dependent on others, prompting some of these changes. Those with paranoid personality disorder are distrustful of others. They have an excessive trust in their own knowledge and abilities, may read hidden meanings into ordinary things or read hostile intentions into the acts of others. They often appear cold and distant. They're quick to challenge the loyalties of family and friends, and they are quick to shift blame to others and carry long grudges. So just as a soft break from all the information, I wanted to just present a little a case of an individual that I saw just to illustrate as we kind of wrap up the differential diagnosis and workup point of the talk about how varied and complex presentation of psychosis in late life can be. I saw a man in the clinic here several years ago, 68 years old at the time, and he was being referred at the time with some significant psychotic symptoms, significant delusions and hallucinations, multisensory hallucinations. As I dug into the case, is really a trajectory that illustrated how complex psychotic symptoms can be and how they can change with age. This is someone who had about a 15-year history of a delusion of a homeless man living on his roof and harassing him, and had otherwise maintained his ability to function socially, occupationally, had recently retired when he first came to me, but had functioned pretty well for years with this belief. The only hallucinations he experienced for quite a while were some auditory hallucinations of footsteps on the roof, or occasionally some whispering. These changed though with time. He didn't seek medical care, psychiatric care for that condition. With time, these changed, and the delusion began to impact his functioning and impact his life more severely. He began to think that the man was coming into his house and pumping gas into his house. He began experiencing olfactory hallucinations of gas being pumped in the house. Even told me that he could smell when the man was there, but was invisible because he could smell his ghost farts, which he told me smelled like decaying leaves. He began to have visual hallucinations that began to spread beyond just the delusion about the man on the roof, began to hallucinate other people in the home, people running crime rings in his home, began to have more widespread delusions about people in the neighborhood talking about him, saying that he was a sexual predator, began spreading misinformation about him, having racist grudges against him, saying he could hear people talking and saying all these things even while he was within his home. Upon seeing me, certainly he had broad psychotic symptoms, but it was interesting in that this case really met criteria for someone with a delusional disorder, and then evolved to something much more, something that really looked more like a primary psychotic disorder of something like schizophrenia in later life. However, through this process of evaluating for secondary causes, he saw neurology, saw myself, got some collateral history, and it became clear that he was beginning to have some difficulties functioning at home around self-care, cleanliness of his place, losing weight, hygiene, becoming less well tended to. And he actually was beginning to have a little bit of rigidity and some autonomic instability. So actually through a diagnostic process, it became clear that he was having early stages of dementia with Lewy bodies. Just had this very atypical course and very complicated course in ultimately receiving a diagnosis that was different than what he had initially experienced in earlier in life that was typical of a delusional disorder. So just to illustrate how complex and how changing psychotic presentations can be in late life, and all the different potential etiologies that you have to entertain. All right, so let's get on to treatment. So since the etiologies are so complicated, of course, treatment is going to be too, depending on what we're addressing. So first thing we need to figure out as we're going through thinking about treatment of psychosis in late life is treatment even necessary? Of course, this will depend on the etiology of the psychosis, but let's think through some potential pros and cons of treating with medication. First, do no harm, right? That's what we all want to do. And the treatment of psychosis with antipsychotics is, of course, complicated by the higher incidence of adverse effects when antipsychotic medications are prescribed to older adults when compared with younger adults. The Beers criteria, for example, recommends that we avoid antipsychotics for the treatment of dementia and delirium, with a few caveats, right? In the setting of dementia, we want to avoid the use of antipsychotics for a number of reasons we'll talk about, unless someone has psychosis that is potentially going to put them or another person at risk of serious harm, and non-pharmacological efforts have not been successful. It's particularly difficult to diagnose psychosis in dementia as well, because it's hard to disentangle things like delusions from cognitive impairment. Like someone talking about speaking with a deceased relative earlier in the day may actually just be describing a memory that they're having, and they're reflecting or living on, since it's a more fresh memory in their mind, since it may have been from years ago, and it may not be a true delusion. In the setting of delirium, antipsychotic medications are also recommended to be avoided. They can actually worsen delirium, again, worsen morbidity and mortality. So we really want to reserve the use of antipsychotics in the setting of delirium for those patients with delirium that are so agitated due to their delirium that their agitation is preventing the necessary medical care that they need to address the underlying cause of their delirium, right? That is the sole function. Remember, there is an FDA black box warning on antipsychotics in the setting of dementia. And there is no FDA indication for antipsychotics for dementia with behavioral disturbances or for insomnia or anxiety. There are FDA indications for schizophrenia, bipolar disorder, major depressive disorder, and Parkinson's disease psychosis. So we can think about these a little bit different because the evidence for using them in these conditions is better. Keep in mind that treatment in schizophrenia improves functioning and outcomes. And psychosis in general is associated with poor outcomes. So we want to think seriously about doing something, even if it's not use of an antipsychotic. Also, psychosis results in higher caregiver distress and can jeopardize placement. And placement, particularly in the setting of dementia, can be a very valuable thing. So overall, right, whether we're going to treat or not depends on a few things. It depends on the condition, the underlying cause of the psychosis that we're treating. So we'll talk a little bit about what we're treating and how we'll weigh use of medications, particularly antipsychotics, which are the staple of treatment for psychotic symptoms of any etiology. And then we want to weigh whether it's necessary by trying other measures first where that's appropriate. So in the setting of dementia, we want to address sensory limitations, make sure everyone has hearing aids, corrective lenses, proper lighting, and having social connection seems to benefit most people with psychotic symptoms as well. Also keep in mind that psychotic symptoms can sometimes be more distressing to the caregiver than to the person experiencing them. So it's important to realize where the distress is coming and if it's really necessary to treat. I have one individual who has significant visual hallucinations in the setting of Parkinson's disease, but it's mostly hallucinating his old childhood dog. And he really enjoys seeing the childhood dog. So there really isn't much indication to treat non-distressing hallucinations in a setting like that. In the case of distress to the caregiver being greater than to that of the patient, some psychoeducation would be a good place to start. Okay, so if we've decided that treatment is necessary beyond non-pharmacological interventions, education, optimizing sensory, optimizing one's sensory experience via addressing sensory impairment, then we need to think about medication selection and initiation. So as a background in general to this, we got to acknowledge that there are limited studies of antipsychotics in older adults. We want to choose a medication with the most empirical evidence for the condition that we're addressing and the best safety and tolerability, and kind of weighing those two things. Definitely have to educate the patient and or surrogate decision maker on adverse effects and risks. This is really important given the considerable risks of these medications in older adults. Document informed consent. Some institutions actually have informed consent forms specifically for antipsychotics. Make sure you're including in your discussion and documentation risks, benefits, alternatives, including the alternatives of not addressing psychosis in a given condition. Document your decision making as clearly as possible. Then when we're going to start an antipsychotic, we're going to start low. Half the starting a dose for a general adult population or lower. In those with secondary psychosis, particularly dementia-related psychosis, or those who are frail, a quarter of the starting dose may actually be appropriate. So in choosing an agent, you're going to do this in joint decision making with the patient or their surrogate decision maker, because in many conditions, particularly secondary psychotic conditions, the effects of antipsychotics are admittedly limited. The benefit is limited. Therefore, it is really important to pay attention to the risks and the adverse effects. A chart like this that kind of breaks down the risk of different adverse effects across agents can be really helpful in understanding where the greatest problems may lie with a given agent. This is just an example table of second generation antipsychotics, comparing their risk of adverse effects. So picking an antipsychotic if you're treating schizophrenia, well, let's look at what we know. There's one important systematic review and meta-analysis from 2018 I want to mention, because it's looking specifically at antipsychotic drugs for elderly patients with schizophrenia. There were 29 references, all randomized controlled trials, over 1,000 individuals, mean ages between 57 and 73. Their primary outcome was overall psychotic symptoms. The results were not terribly surprising, but at least this was a nice comprehensive look at these medications in this population. So we can draw a few conclusions from what they found. Paliperidone had fewer dropouts due to inefficacy than placebo. Again, not surprising. Olanzapine was superior to haloperidol for overall symptoms and negative symptoms. Risperidone and haloperidol increased prolactin more than olanzapine did. And olanzapine had less use of anti-Parkinsonian medication than haloperidol. Not surprising. What else do we know? Well, there really is overall a dearth of high quality pharmacotherapy studies in this population, particularly in late onset schizophrenia and very late onset schizophrenia like psychosis. The largest and best trials are of risperidone and olanzapine. There are smaller trials of newer second generation antipsychotics. We do know that it seems both first and generation antipsychotics are beneficial to psychotic symptoms, but they are limited by their adverse effects. And for those of you who are more comfortable with the older terminology, first generation is typical antipsychotics. Second generation we refer to as atypical antipsychotics. Most folks in the psychiatric community are referring to them as first and second generation now. It is worth noting that there is considerable pharmacological heterogeneity even within these first and second generation groups, though. So what can we draw from it? From the available research, the treatment of early onset schizophrenia in late life using risperidone and olanzapine has level 3 evidence in a meta-analysis. So those are both commonly chosen agents. There is little evidence to support the use of clozapine in treatment-resistant geriatric patients due to its significant side effect profile. So as much as us psychiatrists love to talk about clozapine being underutilized due to just the hassle of prescribing and monitoring it, the risks in a geriatric population are considerable. And there's not a lot of evidence to support its use in most geriatric patients with schizophrenia. Haloperidone also has some efficacy compared with placebo in the treatment of elderly patients with schizophrenia with level 2 evidence. So another commonly chosen agent. Now let's talk a little bit about choice of medication for psychosis due to dementia. Given that psychosis is a key component of dementia with Lewy bodies, I want to focus specifically on this type of dementia. We can talk a little bit about choice of agent in other neurocognitive disorders. So in the setting of dementia or psychosis related to dementia, in general, we're talking about, again, selecting medications, presuming you've already done deprescribing of agents that could be exacerbating psychosis or other behavioral problems, and you've tried non-pharmacological interventions. This is if we're going to be treating dementia-related psychosis. So in the setting of dementia with Lewy bodies, both donepezil and rivastigmine can improve cognition, and there is some evidence for improving psychotic symptoms and quality of life. So if a patient is not already taking one of these acetylcholinesterase inhibitors, they can be entertained. The safety profile is also better than that of an antipsychotic, so maybe a good first-line choice for those experiencing psychotic symptoms. Now, if we're going to use an antipsychotic, our choices are limited because of the impact on antipsychotics on dopamine transmission. So we have just a few choices. Clozapine has level 2 evidence for treating psychosis in the setting of dementia with Lewy bodies. This is because it has greater serotonergic affinity and selective binding of the D1 mesolimbic receptors, while it really spares the striatal D2 receptors implicated in the deterioration of motor functions. So this actually is a pretty tolerable medication and has good evidence for response with psychotic symptoms. Though quetiapine is used very often, primarily because it's easy to use, it's available, and relatively tolerable compared to clozapine, it does not have great evidence. There's one systematic review that really looked at it in this population and found only one open label trial that was able to report a significant reduction in psychotic symptoms. Otherwise, the trials have been negative. Pimavanserin is a serotonin inverse agonist, and though it is FDA approved for Parkinson's disease psychosis, it has demonstrated efficacy in improving psychotic symptoms, not only in Parkinson's disease, but also in a study involving mixed phenotype dementia-related psychosis, and research using it is ongoing. So if we're thinking about other types of dementia, I want to mention Parkinson's disease dementia, because these same agents are our options for that form of dementia as well, due to the sensitivity to anti-dopaminergic antipsychotic medications. The difference being, if someone has Parkinson's disease dementia and is treated with anti-Parkinsonian medications, prior to jumping into these medications, we typically have a close bond with neurology in addressing the anti-Parkinsonian regimen and seeing if motor symptoms will allow any deprescription or reduction in adjunctive therapy, dopamine agonists, or carbidopa-levodopa, typically in that order, to reduce psychotic symptoms prior to initiating one of these medications, including antipsychotics. For other forms of dementia, The management is really similar to the management of agitation. And unfortunately, that's a problem in many trials of dementia-related behavioral disturbances, is that there's not a lot of parsing out of the type of behavioral disturbance being addressed and the medication looking at it. Antipsychotics have, of course, been studied for dementia-related agitation or behavioral disturbances broadly. We may all be familiar with the fact that these medications have considerable risk in this population. And unfortunately, the effect of them on both agitation and psychotic symptoms is limited. The overall take-home point is that if an antipsychotic medication is going to be used for a dementia that is not dementia with Lewy bodies or Parkinson's, the greatest evidence falls with risperidone and aripiprazole. So those are two of the most commonly selected agents in those cases. Now, if we've selected and started a medication, we have to think about how we're going to titrate it and what we're going to monitor for. Well, you've heard it before, go slow. In our older patients, particularly with antipsychotic medications, take your time in escalating the dose, and we want to aim for the lowest effective dose. Frequently assess the target symptoms, what we're wanting to get better, and side effects, which we'll discuss more in depth. Remember, these medications require some routine monitoring, including AIMS exams, checking for abnormal movements, as well as rigidity. Labs, including metabolic labs, hemoglobin A1C, lipid panels, weight, and EKG. And of course, avoid polypharmacy. If someone has refractory psychotic symptoms, we can talk about how to address that. Certainly don't just start throwing everything at them. In the setting of schizophrenia, how do we want to titrate medication? Well, it's really worth noting that those with late onset schizophrenia and very late onset schizophrenia psychosis require lower dosing of antipsychotic medications compared to those with early onset schizophrenia who have aged into the disease. Extrapyramidal symptom risk is very high in these later onset forms of psychosis, especially in very late onset schizophrenia-like psychosis. The recommended dosing is based on expert consensus due to lack of information being published through RCTs in this population. Risperidone is generally thought of as the first-line agent. And you can see the dosing 1.25 to 3.5 milligrams per day. Alternatively, experts recommend use of quetiapine, olanzapine, and aripiprazole as alternatives. In dementia with Lewy body psychosis, remember, caution when you're prescribing these and titrating them, be careful. The risk of rigidity, neuroleptic malignant syndrome, and death as a consequence of underlying disruption of dopaminergic transmission is real. Those with dementia with Lewy body are exquisitely sensitive to antipsychotics. This is worth noting in Parkinson's disease as well, but indeed those with dementia with Lewy bodies are particularly at risk. Remember, if you're going to be using clozapine, even though it has decent evidence for addressing psychosis and dementia with Lewy bodies, it has a significant side effect profile. And it goes beyond just the agranulocytosis that requires weekly labs. Orthostatic hypotension and sedation are both significant and can be problematic for an older patient. What do we want to monitor for? Well, the risks of all medications go up with older patients. The risks of antipsychotics are considerable. Sedation, anticholinergic effects related to that, orthostatic hypotension. Extrapyramidal symptoms are almost 6 times more common in older than younger adults. QTC prolongation, metabolic side effects. Acute kidney injury is actually more common in those receiving antipsychotics. And then these bottom 3, Risk of stroke, cognitive decline, and death are more common in those with dementia. So as part of the whole treatment protocol here, we have got to talk about reduction and discontinuation. We don't just get folks on antipsychotics no matter what and leave it there. Really depends on the condition we're treating, but reduction and discontinuation may have a clear role. So if we're talking about secondary psychosis secondary to another condition, including dementia, well, how long do we treat? There's no clear data on how long to treat. Most experts, though, recommend if you're treating secondary psychosis, maybe after 3 to 6 months of stability. I'd suggest potentially sooner. 3 months sounds pretty good to me. If you needed to use an antipsychotic, we want to stop it as soon as we can after there's been some period of stability. But we want to taper, don't stop abruptly. Gradual dose reductions, or GDRs, may be language familiar to some of you. When we're using antipsychotics for dementia-related psychosis, we have to consider those dose reductions at least every 3 months. And this is actually mandated in long-term care settings, along with use of other psychiatric medication for behaviors. And this is along the lines of just the general principle that we want to be using the lowest dose of medication for the shortest duration. If treatment has failed, again, don't just throw more medication. Reformulate the diagnosis. Go back to that differential diagnosis and workup, those steps, and redo the medical, neurological, pharmacological evaluation to see if there's an etiology or a contributing etiology that was missed. Also reassess the previous medication trials that you've done. Have they been of adequate dose, of adequate duration? And if all else fails, don't hesitate to get consultation from a colleague. Now, if we're talking about reduction and discontinuation, what does that mean in someone with a primary psychotic disorder? Well, even though these medications are so risky in older adults, we don't just want to throw them away in those with a primary psychotic disorder like schizophrenia. The data really are limited regarding discontinuation of antipsychotic medications in older adults with chronic schizophrenia. The recommendation is to attempt discontinuation of these medications in these patients only if they have not responded to them, or those who have had long-standing clinical remission, keeping in mind that third group, that 1/3 group that actually ages with significant reduction or even remission of psychotic symptoms. And I've experienced this as well, folks who have had a convincing history of schizophrenia, who come in late life having been on an antipsychotic for many decades, are symptom-free, and as we reduce the dose, seem to no longer have any prominent psychotic symptoms. So those patients are out there. If discontinuation of the antipsychotic isn't feasible, you can consider decreasing the dose of antipsychotics to the lowest effective dose to minimize that risk of adverse effects we're so concerned about in older patients. And this can be done conservatively in some patients without worsening of psychotic symptoms. What about ECT? We often hear about ECT is being used for psychotic symptoms. Well, ECT is safe in all ages, though there are fewer studies in the geriatric population. I mention this here because it is very effective for the treatment of psychosis in the setting of major depressive disorder or bipolar disorder. It's so effective, I don't even mention the use of or selection of antipsychotic medication for those with psychosis due to these affective disorders, because ECT is just more effective and safer. However, there is a smaller body of literature looking at ECT for use in schizophrenia or secondary causes of psychosis. There's one selective review report reporting that prospective trials of ECT in psychotic elderly patients have shown that bilateral ECT is safe and effective for treatment of older patients with schizophrenia, and it can be synergistic with concurrent antipsychotic therapy. But the best evidence really is for those patients that are presenting with aggression, catatonia, or other cases that require a rapid response, like acute suicidality or an acute onset of illness. So not a mainstay of treatment of psychosis by far. It is worth mentioning too that psychosocial treatments can play a really important role in primary psychotic disorders in older adults. There are a number of programs with all these acronyms that stand for cognitive behavioral social skills training, functional adaptation skills training, and then this study with the name HOPES, Helping Older People Experience Success. These are all programs that are focus on cognitive behavioral intervention, social skills training, everyday living skills, preventative health care, and vocational counseling or support. And they have been conducted in both middle-aged populations and older adults with primary psychotic disorders. And they've shown benefit to psychotic symptoms, social functioning, and living skills. So in summary, a big and varied topic, but I want to make sure you take away a few key points. Psychosis in late life has variable presentations and variable etiologies. The secondary causes of psychosis are more common than primary psychotic disorders in late life. Keep that in mind. The workup should be really thorough to rule out a variety of potential medical, neurological, or medication or substance-related causes of psychosis. The most common cause of late life psychosis is dementia, period. Early onset schizophrenia has a considerably heterogeneous course into late life. Don't forget, some people actually have improvements, some have stability. And then late onset schizophrenia and very late onset schizophrenia-like psychosis are important terms to describe presentations of primary psychotic disorders with later life onset and greater female predominance. Keep in mind, older adults have a much higher risk of antipsychotic adverse effects, particularly extrapyramidal symptoms. Antipsychotics have that FDA black box warning for their use in the setting of dementia, and there are nearly no FDA-approved treatments for psychosis related to dementia or delirium. I have that because of pimavanserin is FDA-approved for Parkinson's psychosis, so in Parkinson's dementia, you have that. But off-label use of medications along with non-pharmacological approaches may be appropriate in individual cases. The treatment here really needs to be individualized given how varied the causes, presentations, and impact on life and stability may be. Thank you so much.
Thanks so much, Dr. LaBardi. This was an incredible presentation, some tremendous breadth and depth on this topic. We had a question earlier that I thought I would pose now. Lisa was wondering, she said, my understanding is that neuroimaging isn't recommended any longer for cognitive changes related to aging and dementia. Is there anything in particular that would be helpful to do neuroimaging with psychosis in mind?
Yeah, so this is, I have this in here at kind of two different stages. So one is the presentation of late life psychosis as new onset. Given how varied the potential causes would be, I wouldn't jump in and do neuroimaging right away. However, I would do it in two particular circumstances. One is if someone does have a very recent history of cognitive decline, because again, that's basically a neurological symptom. Or if someone has other focal neurological symptoms, that would be wise, I think, to do neuroimaging. And you can argue about what type of neuroimaging to get, but I think that would be wise. The second is as part of a cognitive evaluation. And I know that there are differing opinions on this. Most bodies, including the American Association for Geriatric Psychiatry and the American Neurological Association, would recommend the use of some type of neuroimaging as part of a dementia evaluation. In most cases, that doesn't mean all. It doesn't mean in someone who has advanced impairment, doesn't mean in someone who's agitated, doesn't mean in someone who's refusing it. But as part of the general workup, that is one portion that is typically recommended. And that's not only to rule out potentially reversible or treatable forms of cognitive impairment, like NPH, for example, or to identify any unexpected conditions like a bleed, a tumor. But also, as we learn more and more about imaging in the setting of dementia, it becomes a tool that's helpful in phenotyping the dementia, which can help with our education for patients and families about their expected course. It can also help with education on what types of treatments may be helpful and how helpful they may be. So use of cognitive enhancers, how helpful they may be expected, and also just what medications we may use for behavioral and psychological symptoms of dementia, since some of them are particularly risky in some dementia phenotypes.
So I hope you don't mind. I'm going to pose a question that's a little bit left of center, but we hear so much. There are a lot of resources available for caregivers of individuals with dementia. And I'm just wondering, from your practice, what's your experience about the issues faced and the support available for caregivers or family members of older individuals with psychosis?
Oh, so what issues come up?
Yeah.
With caregivers?
Yeah.
Oh, yeah. I mean, it really depends on the caregiver, but I think so often, even a caregiver who's really sort of thrown themselves into learning about dementia and the cognitive and functional changes that occur, sometimes seems blindsided by psychotic symptoms, right? They're so unusual when someone has never experienced them otherwise in life, right? When someone begins saying that there's a person standing over there, or don't you see that cat? It can be really jarring. And I think, psychoeducation can go a long way in just knowing that these are common symptoms, and that depending on how they're manifesting and how distressed the patient is, they may not be as awful as the caregiver is assuming. So I don't know if that answered your question, but I just feel like psychotic symptoms are particularly jarring because most caregivers don't seem to expect them in the setting of dementia.
Mm-hmm. And do you have a sense that the resources that are available for caregivers of dementia are also adequately addressing the issues that come up related to psychosis?
Oh,
The resources, sorry.
That's a good question. I've got a great team here. So, myself and the social worker and nurses that I work with are good at helping to provide that additional education. But you're right. I don't think it's necessarily adequately touched on in a lot of forums. When I get on the Alzheimer's Association website, I don't see psychosis covered as often as a lot of other topics. I don't know how often it's covered in caregiver support groups, how much people are really talking about it. So that's a good point. I'm sure it could be a lot better in many forums.
Thanks so much for that. Any other questions, folks? I don't know if you've seen the chat, but there are several people who have said they really want to watch this again. It was so rich with information and so helpful. So thank you so much, Dr. LaBardi. Really appreciate it.
Yeah, no, it's my pleasure. Thank you all again.
All right. We'll see everyone next week then. Have a nice evening. Thanks, Dr. LaBardi.
Thank you.